Hi there, welcome to the Myositis Association's Ask the Doc webinar series. My name is Rachel Bromley. I am the Senior Manager of Patient Education, Support, and Advocacy for the Myositis Association. And tonight we have the honor of speaking with Dr. Victoria Werth. Dr. Werth is a professor of dermatology and medicine at the University of Pennsylvania School of Medicine and chief of the Division of Dermatology at the Philadelphia Veterans Administration Hospital. Dr. Werth earned her medical degree from Johns Hopkins University School of Medicine in Baltimore, Maryland. She completed a residency in internal medicine at Northwestern Memorial Hospital in Chicago, Illinois, and dermatology residency and immunodermatology fellowship at New York University School of Medicine in New York. She joined the faculty at the University of Pennsylvania in 1989 and has developed an internationally recognized program in autoimmune skin diseases. She is a co-founder of the Rheumatologic Dermatology Society and previous president of the group. She is co-founder of the Medical Dermatology Society and a recipient of their Lifetime Achievement Award. She initiated the Combined Internal Medicine Dermatology Residency Program in the U.S., which has successfully trained prominent leaders in complex medical dermatology. She has a long-standing interest in clinical and translational research pertaining to dermatomyositis, with a focus on improving the treatment and outcomes. She has developed and validated disease severity tools now used in many international trials in dermatomyositis, with a goal to advancing evidence for current and new therapeutics targeting these diseases. Her laboratory studies include studies of mediators of inflammation in dermatomyositis and understanding mechanism for dampening immune responses. Recent clinical studies have examined mechanistic effects of therapeutics in dermatomyositis. Her work has been funded by the Dermatology Foundation, NIH, DOD, the VA, numerous autoimmune disease foundations, and industry. Dr. Werth is also a member of TMA's Medical Advisory Board. Dr. Werth, welcome and thank you for being here. If you have a question for Dr. Werth, please type it in the Q&A box at the bottom of your screen. Before we start today's Q&A, Dr. Werth will take a few minutes to share her work.
Okay, hopefully you can see my slides, and it's great to be here. These are my conflicts. I do work with industry because we need new therapies, as all of us on the call know, and I also, the CDASI is a outcome measure that we developed, and I will be discussing off-label use of medications. I'm involved, as you heard about, with the Medical Advisory Board for the Myositis Association, and I have other involvement with dermatomyositis and from clinical trials to basic science and translational work, and also work with the group called IMAX looking at outcome assessments. So I'm involved with a number of clinical trials, and actually I had a grant from NIH, I still do, looking at CB2 agonists and the skin and dermatomyositis. I'm also involved with an anti-interferon beta trial, as well as sub-Q IVIG or Hizentra trial. So I wanted to just start out with a little overview of some of the recent studies that we've put out over the last year. You probably know that if you have skin-only disease, sometimes we use hydroxychloroquine. This can sometimes cause a reaction. In fact, not infrequently, about 20% of people. But for people who respond, it can mean that your skin gets better and you don't need to advance therapy. Sometimes when the hydroxychloroquine alone doesn't work, we will add quinacrine, and I'm showing you here that there's some patients, mostly highlighted in blue here, that you can see after starting quinacrine at time 0, the skin score comes down pretty quickly. And so there are subsets of people where quinacrine can be very helpful. And so right now it's very difficult to get it, but hopefully we'll get it back in the future. But we're always looking for non-steroid other approaches to treating the skin. So we did a study using our Perspective database, and we have almost 500 patients now that we have followed at Penn. And many of these patients have been either exposed to mycophenolate mofetil or to methotrexate, and we were interested in knowing how quickly people get better if they're going to respond, and if they start to get better, how long does the continue to get improved after being started on the medication. So on the MMF side, you can see that it can take, people are still getting better as long as a year out for the ones who are responding, and then in red you can see there are some people who do not respond. And we found a very similar trend with people with methotrexate, getting better, sometimes very much at the beginning, but then slowly still continuing to improve over a number of years. And so this is actually interesting because if you're in a study and people are on background medications like MMF or methotrexate, you can see that that might make it harder to see an effect of another agent added because there's a continued effect over a long period of time with that other background medication. Again, either MMF or methotrexate. Now, I did want to also highlight that we are finding that there's certain herbal supplements that probably, if you have dermatomyositis, you should absolutely, not even probably, you should absolutely avoid. And one of the ones, and this is not herbal, but a weight loss powder, isolene, we found a number of patients had problems with this and actually exacerbated or had new onset disease shortly after taking isolene. And these are known immunostimulatory herbs: spirulina, blue-green algae, chlorella, echinacea, alfalfa. And I could tell you that so many foods have spirulina that you almost have to read the back of packages. Or if you take over-the-counter supplements, you may find they have spirulina in it. There's certain juices that have it, along with chlorella or blue-green algae. And these very clearly stimulate the immune system. And I'm absolutely convinced that many of the patients that I see flare in the setting of getting some of these. So read the labels and try to avoid this. We actually found that in dermatomyositis, about 20% of people were taking some form of immunostimulatory herb supplement, and a lot of that was spirulina. And it seemed that people with dermato were much more likely to be on it relative to other autoimmune conditions such as lupus or blistering disease. So I do believe that there's something different about people who are predisposed to getting dermato, that in particular, they're more problems with these kinds of exposures. This is looking in the lab where we added spirulina directly to peripheral blood mononuclear cells from patients with dermatomyositis. And you can see that at rather low doses, you get stimulation of cytokines such as interferon beta or TNF. And these are known to be mediators of inflammation in patients with dermatomyositis. So we really do know that this stimulates the immune cells in ways that are probably not a good idea. Now, we did a study with linabacim, and this is a drug that has effects on CB2, and it's an agonist, and what it does is it basically downregulates inflammation. And so this was a phase 2 trial that was randomized placebo-controlled. So the orange is the placebo, and the blue was the people who got linabacim. And they were treated for a total of actually 12 weeks and then followed out another 4 weeks. And you can see that there was a separation of the curves as soon as actually the drug dose was doubled, which happened at 4 weeks. So it was pretty impressive that the patients did better here. And this was the kind of improvement that we saw from red at baseline to at week 12. You can see quite a bit of improvement in erythema. Now, this wasn't in every single patient, but the people who improved did really quite well. And in addition, they thought they did well. They reported the activity is improved. And you can see, again, placebo versus the treatment group. And the symptoms were better, and also the pain was better. So this was quite encouraging. We did a lot of work in the lab looking at cells, and you can see linabacim treated group at the beginning with more inflammatory cells labeled here in brown, and then getting better by week 12. There are not so many brown cells, whereas the placebo group, there wasn't such a change. And you can see that here in the quantitation of the cells that we saw in the skin. And then we did a long-term extension that went on for almost 3 years, where you can see that the activity in the skin continued to improve and stayed improved. And we've actually followed people now who've come off the drug and been off. And people are now, some people, started to worsen even a month or two out, but some have gone as long as a year and then started to flare again. So we really do think there's a subset. It certainly did not work for each person, but where it was helpful. And this is looking at the symptom score, which, as you can see, also continued to improve over time. So it was safe and tolerable. I mean, some people had a little bit of fatigue, but nothing serious. And the top level phase 3 results came out in June a year ago, almost a year ago. And there you can see that because of the FDA, there had to be a switch from a skin outcome to a muscle, the TIS, which favors muscle over skin. And so it's hard to detect improvement in skin. And the patients had more muscle as well as skin involvement in many cases. So what was found was that people who had were quite weak, there was a improvement in the muscles, and in people who had more skin disease, there we could document the skin improvement with the skin score, and these people also did it better. So we had a phase 2 study that showed skin got better, and a phase 3 that if you looked at the subset of people who only had skin, there was also improvement. So we're still doing a lot of work on this study, but unfortunately, because of the negative result in the phase 3, this is not going to be carried forward, but there's certainly interest in this CB2 agonist, and so it's very important that we complete the work that NIH funded and understand how this medication is working. We looked at CB2 in skin, and this is looking at immunofluorescence, looking at CB2, and then also here we're looking at a different method of looking at CB2, and you can see these are red, but there's much more staining in the skin in the dermato than in the healthy control here, where it's hard to find red cells that are staining. And so there's clearly much more upregulation of CB2 in people who have dermatomyositis. Now, I've had some questions ahead asked about IVIG, so I put this slide in to show the one trial that's been successful for dermatomyositis, which was a IVIG study. And what this is showing, this is actually Optigam. It was a company that had that particular IVIG preparation. And you can see that there's a difference between improvement of the score, the TIS score, in the patients who got drug versus those who did not in terms of the IVIG. So this is really reassuring, and based on this, IVIG was approved by the FDA a few months ago, and it's a little bit easier to get coverage.
Dr.
So,
Werth, Dr.
yes,
Werth,
yeah.
we had a request if you could just slow down just a little bit, please, with your
Oh,
speech.
sure. I'm happy to do that. I was just hoping to leave time for questions,
I know.
but I will certainly slow down. So we also know that in the skin, blood, and muscle, there is an interferon signature, and that can be either interferon beta or interferon gamma. And these can be upregulated, and when treatments are effective, these can also go down. And we have found that with our linaprazan trial that the patients who did better and who got drug tended to have improvement in these inflammatory proteins that were in skin and in the blood. So we think that this is a good way of thinking about how to target, and there's actually now an ongoing study that targets interferon beta, which we know is an important inflammatory cytokine, and that's actually ongoing trial. We don't have any results yet. It's a phase 2. But I think that it's going to be good news from what we can see, and hopefully they'll be going on to a phase 3 trial. But and we'll see how well that would work in a randomized placebo-controlled phase 3 trial. This is just showing interferon beta correlating with the transcript level for, in other words, is a score you can get out of the blood. And that score really correlates nicely with this particular protein that I told you about, the interferon beta, also with gamma. And so those seem to be major drivers in the skin and the blood. Now, we've been able to go on and look in the skin and see what cells are there. And one of the things that we found out is that there are dendritic cells in skin, but they tend to be more what we call myeloid cells and not so much plasmacytoid dendritic cells. And that's something that really hadn't been known before. And so we recently reported that about a year ago. We know that itch is a huge part of dermato, and this was a study that showed that there's another protein in the skin that's produced by a number of different cells, and it's called IL-31, and that seems also to correlate with itch. And so you can see here in skin of somebody with dermato or a number of people with dermato, the IL-31 is high relative to non-lesional, and that's even higher than what we see in healthy control. So IL-31 is up in the skin, and we found that the expression was correlating with the degree of itch. So the more itching, the more IL-31. And so that's also interesting to think about as, is that a target for some of the itching that goes on here? So this is just showing you some fancy ways of even more, this is a tissue mass cytometry, but it's a way of actually looking at all the cells that are in the skin that we wanted to label. And then you can look at what the cells are making. And for instance, interferon beta is this column right here. And these are different cells you can find in the skin. And so based on this kind of study, we can say which cells are making interferon beta predominantly in patients with dermatomyositis. And so this is really interesting and helpful information when you think about what cells and what cytokines to target. So I want to just talk briefly about the skin manifestations of dermato. And we know that the skin findings in classic dermato, which is skin and muscle, are identical to those who only have skin. They are exactly the same. And so that can be confusing because in the past, there were criteria for dermatomyositis that relied on people having muscle disease and kind of discounted skin. And so what would happen was you could not even be called DM if you didn't have muscle disease. And so all the patients that have amyopathic dermato, which is about 60% of my practice, could not be diagnosed with dermatomyositis and were called other things. And so it's very difficult. Some people get called lupus. Part of that is that the biopsy in the skin, which is very helpful in defining that whether or not you're in an autoimmune category, does not differentiate between lupus and dermatomyositis. And so you have to look at what the skin looks like and the results of the biopsy to be able to come up with the correct diagnosis, realizing that older criteria didn't work. So in my own practice, I would say more than half the people who have dermato don't get called dermato prior to coming in the door. And so what they get called is lupus, undifferentiated connective tissue disease, aren't diagnosed, or maybe psoriasis or eczema or something else. So this is a huge issue that people can't get diagnosed, and especially given that people could have an underlying lung disease or malignancy. It's really important to be able to diagnose this disease. So I've worked really a lot with a group led by Ingrid Lundberg in Sweden to try to improve on the criteria for dermatomyositis so that you could recognize people who had skin-only disease. And so now the new criteria called the EULAR ACR criteria recognize patients that have 2 out of 3 of these findings, namely redness over the eyelids and then redness over the joints, either as papules or as just flat, what we call a Gotrin's sign. And we know with these new criteria that we can identify about 73.7% of the patients who have amyopathic DM, which means no muscle. So it's not perfect. There's still over a quarter of people that don't get diagnosed with these new criteria. And so we're actually working now in an international study to try to improve on the skin criteria and to see if we can better identify more patients who have dermatomyositis so they can get treatment, evaluated, and so on. So in summary, we have a lot of new therapies that are in the pipeline. We have improved understanding of some of the causes of the skin disease, but many ongoing studies. And we have new criteria that are much better than the old criteria, and we're working to make the skin criteria even more sensitive. And with that, I'm going to stop and hope to answer some questions.
Thank you so much, Dr. Werth. On behalf of TMA and our audience, we thank you for the critical work that you do. So if you have any questions, please put them in the Q&A box at the bottom of your screen. We're going to start our questions. If we don't get to all of them, then we will automatically submit them to our next DM Ask the Doc. So Dr. Werth, one of our questions is about mechanics hands. Does it get worse if the hands are directly exposed to the sun, or does sun exposure on other parts of the body still increase mechanics hands?
Right. So first, to define mechanics hands, that's the roughness and scale and sometimes redness that's usually on the sides of the fingers. So not on this part of the finger here, but it's really the sides. And so that's not an area that's typically sun exposed. And we know that it can be associated with certain antibodies that are found a little bit more often in people who have lung disease. we don't think of the side of the finger as being a particularly photosensitive area, so that probably doesn't get so much worse with sun exposure. What does get worse is everything else, right? All the other red areas that are in like on the face or on the extensor arms, outside of the arms, the V of the neck, the upper back, those are very sensitive, and we use a lot of sunscreens, SPF 70 or higher. 30 is not high enough, and you want to really go out early morning, late afternoon if you know you're photosensitive. Wear sun clothing that protects your skin. So the sun is a problem, but not typically for mechanics' hands.
Okay, thank you. You talked briefly about supplements that you shouldn't take. Someone in the Q&A box asked if taking zinc supplement is okay.
Yeah, zinc does not seem to cause problems with stimulating the immune system that we know of. I mean, I will emphasize that a lot of these have not been really studied adequately, but zinc is pretty routine mineral found in many things, and I would not be so concerned about that.
Okay, thank you. Any tips for soothing narcotics itch?
So I think the issue is really just itching. It can be horrendous, and so in antihistamines, which block the itch related to histamine, don't really work because it's not mediated by histamine. And so we often will tell people to use things like Sarna lotion, which has menthol in it and can help with itch. Sometimes the antihistamines can help just because you can sleep better. And I think that the itch with some of the newer therapies coming along is going to work. Potentially, there are new ways to target IL-31. I think we have a lot of new uh, ways to proceed, but right now it's still just symptomatic relief with things like Sarna lotion, emollients, things like that.
Okay. Can you explain the relationship between myositis and connective tissue disease?
Sure. So connective tissue disease is kind of an umbrella term, and there are many, many diseases that fall into that. And so, I mean, ranging from lupus, scleroderma, vasculitis, rheumatoid arthritis. So it's really a wastebasket, and dermatomyositis is one of those diseases that fits into that quote unquote wastebasket. But there are also people that can have overlaps between more than one disease. And so they may have more than one connective tissue disease, or some people, they don't quite meet criteria for dermatomyositis or for an autoimmune disease, but they fit in that category.
Okay. How often do you recommend cancer checks and which ones?
Yeah, that's an area that is being actively examined, and there's not total agreement because there's just not enough data to really say what the right answer is. But typically, and especially for older people, we do get a CT of the abdomen and pelvis and chest to make sure there's not something there when the dermato is being diagnosed. And then the follow-up, usually the risk is just the first 2 to 3 years, and so there's not a great data to say how often should people be followed up. Some people would say once a year. Some, it really depends a lot, I think, on the situation, the family history, if somebody has other symptoms, but, probably at least one more time after the initial diagnosis, one should be followed up. There are some cancer markers that are not that good, but also routine exams. Like it's really important to do mammogram, colonoscopy, if that's the right thing to do, or if there's a family history at maybe a younger age. Pap smears, prostate exam, all these things are really, really important to do, and in terms of routine maintenance going forward after the diagnosis as well. So those are the kinds of evaluations that can be done. Now, some studies have been done looking at, for instance, PET scans, which have a little more radiation, and it's not really known yet if that's going to be more advantageous or not. The data is really not in to be able to say that there's anything more than what I just mentioned before that should be done.
Okay. Does DM ever go into remission?
Yeah, so that's a great question. So I definitely have people that have gotten off all medicines and have done really well. And it's hard to predict who those people are going to be. Sometimes there's certain antibodies that seem to lead to more of what we call monophasic disease, where you treat the initial disease and then it seems to go into more of a quiet phase. But then the other people, it kind of can recrudesce again. And we know with sun exposure or maybe some medication exposures that things can aggravate. So I would say, it's there are some people who do go into long-term remission. I would not, don't really know the actual percentages, and I think it's hard to know that, especially when you have a referral practice where you might be seeing more extreme disease. But I don't, it's not a high percentage of people where that happens.
What do they count as remission? Is it a certain length of time without a flare qualifies you to say that you're in remission?
So, I mean, that gets into definitions of remission, which might be different for each disease, and I don't think we even have one for dermato. I think a remission
Right.
would be, could either be, on or off therapy, or, maybe some kind of low dose therapy. So, it could be, it just means that an absence of symptoms or signs of the disease, and then you would say, how long did that go on? But, it's more a matter of whether the symptoms and signs have resolved.
Okay, our next question is also about remission. It is, are there any drugs presently being tested that provide a road to remission for DM?
So, yeah, it's a great question. I think that we don't know is it's a short answer. I mean, I definitely feel like the drug we did study, linabasum, some people went into remission and stayed in remission for a very long time. And so I think that you can downregulate the immune system. But, it's hard to know. There are different triggers that can cause recrudescence. I think many of the therapies that are being looked at right now more mitigate inflammation while the people are on therapy, and I suspect if they were to stop, that many people would relapse. So I can't say that anything is like a cure, so to speak, but I think it's so important to control the symptoms, which are so miserable for people, and the signs with the redness and everything else. So I think that's sort of the where we're getting better.
Okay. How long on average do you encourage patients to remain on methotrexate? And can it take several months for some patients to see improvement?
So that was one of my early slides, and I was like showing that the initial improvement is you can usually tell in the first few months if you're going to start to improve, but the improvement can continue to happen over several years. And if you're just treating skin, I think that it might require being on methotrexate for a fairly long period of time. And for some people, they stay on it for in order to control their symptoms.
Okay. Would papules show up more purple than red in persons of color?
Great question. So one of the things that can happen is in people who have darker skin, as it heals, you get more pigmentation in the skin, and so and almost like a brownish color, which can make it hard to see the red sometimes in people who have really darker skin, especially if there's an overlying pigmentation that happens in response to the inflammation. So I would say you can see purple discoloration in people who have lighter color skin. I don't know that I would say it only happens in people with darker skin. I think the bigger issue is if you can't see the erythema because of the pigmentation.
Okay. Does rapidly worsening Raynaud's syndrome reveal anything about the type of myositis one has?
Not really. I mean, anybody can get Raynaud's, and it doesn't really tell you that much about what the course is going to look like. I mean, I think, it's more common to see Raynaud's, for instance, in things like maybe lupus or scleroderma. So, with Raynaud's, you'd want to make sure there's not an overlap or something else. But we have lots of people who have Raynaud's with their dermatomyositis, and it doesn't really tell you anything else.
Okay. Can you please explain the difference between IVIG and SCIG and how it's determined which one is used? Are daily SCIG shots available to DM patients?
Okay, so there is an ongoing study right now with subcutaneous IVIG, otherwise known as Hizentra. And Hizentra is available for replacement for people who have hypogammaglobulinemia, so it is on the market. But the doses that are needed for dermatomyositis are really quite different. And so typically what's done is to dose usually several times a week with a fairly high volume that requires a pump to put that volume into the skin. And it's very helpful to have that approach for people who don't want to be hooked up to an IV pole or want to have this done when they're traveling and they can take the pump and do it themselves. But it's not right now it hasn't been approved. That's why we're doing a study, which is it's not an easy study to do. So if anybody's interested in hearing more about it, I think it'd be nice to be able to have that available as more of an option for people.
Okay. I have had a couple of questions about, do you have any supplements that you do recommend for DM?
So, I would say there's some that I don't worry about. I think multivitamins that don't have herbs in them that are stimulating are probably fine. Some people will find things like turmeric, which is probably a little bit of a down-regulating the immune system. I haven't really found anybody that was sure it was helping them, but at least it's probably not hurting them. So I think the main thing is to avoid not all these herbs have been studied, and I've had some patients who've gone to like a street fair and just taken some herbal thing that was given out, and then they suddenly had a flare of their stable dermato. So I just think it's more to be suspicious of things, and my patients now know to ask, is this safe to use? Can you look up the ingredients? And I'm really happy when they reach out because it's not infrequently we'll find spirulina or other things on the labels and tell people, you should not do this. So rather than advocate, I just think it's important to know what to avoid.
Okay. We have a question about someone has DM, but they don't have the rash. They have muscle weakness. Do they still need to be careful about sun exposure?
So what I would say is there are some patients who are photosensitive and they probably know who they are. If they go in the sun, they go to the beach, their muscles get worse. That's the kind of person that should be careful. But I think, if it's mainly about if they don't have any skin and they don't notice any worsening, then there's no reason necessarily to avoid the sun. So I think that has to be determined by, each person's a little bit different.
Is joint pain common with DM?
Yeah, you can get an inflammatory arthritis, joint swelling, the deformity. It can be very, very problematic, and that's another reason to go on treatment is to control that because it's not at all infrequent.
Okay. And we're going back and forth with the questions a little bit because I'm asking the ones from the email and then I'm also trying to get to the ones in the chat. So I'm sorry if they're kind of all over the place, but how long do you recommend staying on IVIG?
Yeah, so there's almost like a no right answer for anything, and the reason is because each person's situation is different. There's some people who have been refractory to any therapy, and IVIG is what keeps them doing well, and so they may be on it for years. And then there are some patients who have an underlying malignancy, and we don't want to suppress their immune system, and we may choose to treat them with IVIG because we don't want to give them methotrexate or mycophenolate. So I think it's basically individualized according to the patient, but very often at the beginning, we may use it as a bridge while we're waiting for other medications to start to work. And so I think, again, it's hard to come up with one answer for that.
Okay. Given that there were new types of myositis discovered in recent years, if someone has been diagnosed with DM, should they ask their doctor for an MSA panel?
Yeah, so what I would say there is it's not so much that they're new types, it's just we have many more antibodies to measure. And I think it is a good idea to probably get a panel, but I will say that one of the bigger problems with the antibodies is that, at least what I see in a lot of the commercial testing, is that they're negative. And so when people have dermatomyositis and they have negative antibodies, then it throws them into doubt that they actually have dermatomyositis. And I think that it's important to know that it may not be there, but I think it's not a bad idea to get them because they may carry some prognostic significance. And I think as the antibody testing gets better, maybe it'll be more reliable.
Sounds good. Someone asked if this episode is only for DM. It is. We've had several IBM Acidoc webinars, and we will have more in the coming months. Next month is rheumatology, and then after that, I think we have neurology again. So thank you for tuning in. Okay, if I think a flare is starting, is the best course to jump on it with medication, or should I tough it out until I absolutely must have medication?
So it depends a little bit on how bad the flare is. I mean, sometimes people will go to the beach and suddenly be doing worse, and then they can use some topical creams, whether it be a topical steroid or, there's some off-label medications that can be used, like a topical JAK inhibitor or Elidel, pimecrolimus or tacrolimus. Those are all things that are anti-inflammatory in the skin, and so you might not need to be increasing treatment. Other people, I have some patients that do flare that need to go on a short course of steroids just to sort of calm everything down. And then if there's a muscle flare and it's severe, then one may need to think about steroids and more aggressive treatment. Or if it's not so bad, maybe upping methotrexate or whatever drug is being used as a steroid-sparing agent. So again, it's hard to have one answer for that. It depends on the severity of the flare, which organs are involved, and how much it's bothering you.
Okay. How do you typically treat early onset muscle involvement?
Often early onset muscle, first off, is to document it. And so the muscle enzymes can frequently be normal even when the muscles are inflamed. And so we would really advocate, especially early on, to get either an MRI or an EMG to document that the muscles are actually involved. A lot of people have symptoms and the muscles are not inflamed. And if that's the case, there can be sometimes fascia over the muscle that can cause problems. And so we like to document for sure that there's muscle disease. If there is, then very frequently the treatment is going to be with systemic steroids for some period of time. And again, the level and amount and length is going to depend on the severity of the muscle disease. And then often, if it's mild, we might even be able to try something like a methotrexate or mycophenolate and see if things settle down even without steroids. But often it would require some dose of steroids for a short time.
Okay. And also, if your question in the Q&A is highly pertaining to your situation only, it may not be asked, because we try to ask the questions that have as much effect on as many people in the population as we can. Okay, does having DM make someone more vulnerable to contagious diseases, or does the associated medication make someone more vulnerable? For instance, COVID.
Yeah, that's an interesting question. Well, there have been some cases of dermato that seem to have started after getting COVID. So there seems to be an autoimmune, and there have been people who get this MDA5 antibody that can be associated with some patients with dermato that is seen in people who don't have dermato in response to COVID. So there's an autoimmune part of this. In terms of the usual infections that people might get, usually it's more because of the medications, the steroids or the immunosuppressives, and less because of the disease itself.
Okay. And continuing with COVID, how long should meds be paused during a COVID infection or following any vaccination?
Yeah. So, I mean, for the vaccinations to take completely, or more optimally, I mean, the thought is that people should probably stop their immunosuppressants for 2 weeks. But I think for some patients, that's probably not a great idea. You don't want to flare your dermatomyositis. So it has to be sort of a balancing act between controlling the disease and trying to get the maximal response from the vaccine. And in terms of the COVID, I mean, I think that if one can stop because of the disease, it's not a bad idea to stop for a short time until the symptoms have resolved.
Okay. Can muscles be irreversibly damaged if they are inflamed and not treated?
Well, I think even if they're treated, they can be damaged, right? I mean, muscles there's activity and then there's damage. And if somebody's had a lot of inflammation in their muscle, after the activity is better, there may be some weakness. It may not be normal muscles, there may be some atrophy. And that physical therapy can be really helpful once once you're started on therapy and starting to get better, and that may help reverse some of the damage. But that can definitely be sort of a normal course of the disease, and certainly treating earlier might prevent as much serious damage if possible.
Forgive me if we've already talked about this. Have we talked about the best way to relieve scalp itch? I know that you talked about some itching.
We didn't talk about scalp itch. There are very potent topical steroids such as clobetasol or betamethasone, which are are called class 1 topical steroids, and they can come in solution form, and they can be applied to the scalp twice a day and can be helpful for itch if there's a lot of erythema and scale. So I think that's helpful. The other thing that I didn't mention before is some people try things like gabapentin for itch to see if that'll be helpful. And I think, there are ways that that can be, can be tried. I don't know that it's always successful, but for some people it does help.
Okay. And then another patient has extremely swollen and painful nail beds from their DM, and topicals have not helped. Do you have any advice for that person?
Yeah, so that's a common thing. There's periungual erythema, edema, sometimes telangiectasias. We often look at the nail fold because you can see a lot of changes with dilated capillaries or dropout in the capillaries. If topicals aren't working, which I find they do if you're using a strong enough topical, like maybe clobetasol on topically, like an ointment, would be helpful. Sometimes with occlusion, maybe wrap it with saran wrap. I mean, there may be ways of doing this that are a little stronger than what you've been doing with topicals. And if that doesn't work, then, sometimes it requires more systemic therapy with some of the drugs we've already talked about.
Okay. We hear that exercise is good for the muscles, but how do we know at what point the exercise could be excessive and could cause a flare?
Well, I mean, usually the idea, it's good to work with a physical therapist who knows how to do the strength training without overdoing it. You don't want to be, running marathons and things like that when you're just trying to get your strength back. And I think it's important to do sort of a graduated increase without overdoing it. I think what you could tell is if you're overdoing it, then likely you're going to relapse or do worse. So you want to do enough, but not too much.
Okay. Does IVIG work for both skin and muscle?
Yes, the studies that I told you about, that was that one trial that was done, did show improvement in skin and in muscle, and works for both.
Okay, good. Thank you. I had a couple of those questions. Um, if a patient only has cutaneous symptoms of DM and mildly elevated blood enzyme levels, should they have a diagnostic muscle biopsy? And should they be on methotrexate, considering it is a strong medication with potentially significant side effects long term?
So let's take the first question, which is about the muscle biopsy. So if somebody is known to have dermatomyositis and they've, for instance, had a skin biopsy and that shows interface dermatitis and they have typical skin findings of dermato, I see no reason to proceed to a muscle biopsy. We have found that MRI or EMG are as sensitive, if not more sensitive, than getting a muscle biopsy, which is pretty morbid. That's not to say you shouldn't ever get a muscle biopsy. For people who have polymyositis or inclusion body myositis or other forms of muscle disease in the absence of skin, I think it's very critical to get a muscle biopsy. But I have not found it very helpful in patients who we know have dermatomyositis with typical skin findings.
Okay. Would you say that labs are a reliable indicator of muscle involvement?
So they're not. There are people who have normal enzymes and complain of muscle pain or weakness, and you get an MRI or EMG, and they are not normal. So I think that symptoms and are equally important to enzymes, and I would proceed on to either imaging or EMGs in the presence of normal enzymes.
Okay. I'm just going over the questions in the Q&A. We had a clarification question for the COVID question. It said 2 weeks stopping meds before vaccines. Does that translate to 1
No.
week prior and 1 week after getting
Yeah,
vaccine or booster?
I think typically what's advised is to stop after, not necessarily before. But
Okay.
this is an art, not a science. There are ongoing studies that are going to look at what are optimal regimens for stopping these kinds of medications. But we do know that being on them does cause a problem with response. So, but we don't know the exact recipe that should be done. But in general, if you look at the ACR website, in general, they're saying to stop for 2 weeks after.
Okay. We have someone whose myositis started not after having COVID, but after two Moderna COVID vaccines. How widespread are you seeing this? This happened within days and weeks, presenting with bilateral carpal tunnel overnight, no previous symptoms.
Wow, this is so controversial, but I think it's a
I
great
know it
question.
is. I know.
It's a really super good question. So we actually, over the last year, I had a medical student who took this on as a project, and we systematically asked every single patient we saw with autoimmune disease, and some of them had lupus, some had autoimmune blistering disease, and many had dermatomyositis. And we asked them, what vaccine did you get? And did you have any kinds of improvement or worsening after the vaccine? So, and we actually have data that we've been presenting at various meetings about this. We found that about 22% of dermato patients after the second vaccine had some kind of flaring. It was typically within 2 weeks. That was the average, the mean time to flare. And most people, things settle back down. They might need a little more therapy for a while, and then to cover the flare, and then decrease the to back to normal. But there are a few people that have had pretty significant flares, and so I think it's good to know about it. It's hard to know what to advise because COVID can be pretty terrible too.
It's true.
And we are even in spite of our data, we're recommending that people get vaccinated. The bigger question that comes up not infrequently now, as you can imagine, is so they had a reaction after their second shot with the initial series. Do they get the booster? And that's a really tough question. And we really don't have any. I mean, I think there were less problems with the booster than we saw with in people who had known dermato than we saw with the second vaccine. And it's interesting, the myocarditis that they're seeing in the kids typically also tends to occur after the second vaccine and 2 weeks out. So it's almost like a very similar process. And more recent data seems to suggest that the booster hasn't caused as much trouble. So, but it's hard to know what to advise, and we don't have that much data about the booster.
Right. How do you decide between methotrexate and IVIG?
A lot of that, well, IVIG is not the easiest approach to life. I mean, I think it's really like a lifesaver for some people, but it can cause headaches, it can cause clotting. Typically, we give it over 2 to 4 days each month. So, and it takes several hours to get it infused. So it's kind of a big commitment for people, and it's also really expensive. It's over $100,000 a year, and occasionally, there might be contaminants, and I mean they really do a good job of clearing and making it as safe as possible. But it's a pretty it gets a little tiresome after a while for people. So, I think methotrexate in some ways, taking pills once a week, you do have to get your labs monitored, but it's just a little less burdensome for some patients. So because, again, the exception I would make is early on, if people are really bad and they want to get some improvement fast, then IVIG might be a good bridge drug. And there are people where they don't get better with methotrexate or mycophenolate, and they need IVIG to function. And then there are other people with underlying malignancies, and really it's much safer to give IVIG in that setting than to be suppressing their immune system.
Okay. I have another medicine question. Is there success with hydroxychloroquine in conjunction with MMF or methotrexate without steroids?
So we have some people that we've treated with just hydroxychloroquine, and if you can use that as monotherapy, it could be really nice. It only works for, I'd say, a quarter of people, and since 20% of people get a rash, you have to do the math and realize that it doesn't work for everybody. But if it works, you might spare going onto methotrexate or mycophenolate. So I still think for most people who have only skin only and not bad skin, it could be a reasonable approach to doing things. There are some patients that are on methotrexate and maybe it's not doing the whole job, and then you might think about adding in some hydroxychloroquine as another alternative.
Okay. What would be the best treatment for inflammatory arthritis with DM?
Yeah, so there I think certainly hydroxychloroquine can help the inflammatory arthritis if it's not too severe. But it takes a while to work. That drug takes a few months actually to kick in. And it may not work for bad inflammation. So that's where methotrexate can be really helpful. And I would say that that would be kind of my go-to drug for somebody with a lot of arthritis. And also they might need some prednisone, if it's really severe and you need a very rapid improvement.
And again, we're jumping back and forth, but that's just the nature of the questions being asked in the Q&A box. Does having DM make COVID symptoms worse than for someone without DM?
So the issue with that is more the medications, right? So medications can suppress your immune system, and we know that that can correlate with worse COVID. But on the flip side of that, COVID can probably induce some autoimmunity. So probably early on, it's good not to be on immunosuppressive, but maybe later when there's more of a inflammatory component, that it might actually be helpful. So I think it's reasonable just to stop when you have COVID for a few days until you're feeling better and then go back on.
Okay. I'm not sure if I'm pronouncing this right, but someone wanted to know is EvuShield or EvuShield helpful for preventing COVID infection in DM patients?
It's helpful for anybody who's immunosuppressed who, might be exposed, and but it's pretty hard to get. And it's in general, at least in my institution, been reserved for people who got rituximab, which knocks out the B cells, so they frequently don't make antibodies against the vaccine. And those people are particularly high risk when they get COVID. So those people are in a lottery system to be able to get EvuShield. So given the problems with access and amount, I think that it depends on what background medication people are on as to whether or not it's something to consider. But there are also other therapies to take if you get infected that are also really helpful if you get them in the first few days. And so if you get COVID and you're on methotrexate or mycophenolate, you may consider going for one of those medications.
Okay. And you may have said this already, but does methotrexate put you at a high risk of severe COVID?
So at higher doses, it suppresses the immune system, similar to mycophenolate and prednisone. And so there's a little more risk if you're at high doses of methotrexate.
Okay, thank you. This patient has DM with a lot of muscle weakness. She now takes Imuran. How do you feel about this medication?
So I think azathioprine is the other name for Imuran, is really good for muscle and joints. And so there are lots of people with dermatomyositis that are managed with that drug as well. And I think of it as fairly interchangeable with methotrexate.
Okay. When told to hydrate for IVIG, what volume is helpful to avoid headaches?
Well, I don't think there's a magical answer there. I mean, everybody's different. So I don't, there are people who know they're going to get headaches and they can get saline, sort of ahead of time to try to increase their volume. But I don't have a magic number for how much to drink. I think what can help if you get headaches that's where we split the dose, and sometimes even over 5 days, getting less each day. And then also slowing down the rate of infusion can be helpful as well.
I was curious about this question. Is frozen shoulder a result of DM, and what can I do about it? I don't even know what frozen shoulder is, so I was curious.
Well, so if somebody doesn't move their arm or their shoulder for a while, it can become frozen. They lose their mobility.
Okay.
And so if somebody's been so weak that they couldn't move their shoulder, then I would imagine you can get a frozen shoulder because it just hasn't been moved.
Okay.
But just to get that, if the weakness wasn't that extreme, I think that would be an unusual finding.
Okay. Do you know of any trials with stem cell transplant on patients with DM or PM at this time?
I'm not aware of any for Dermato.
Okay. Let's see. Let me look in the Q&A. We have time for maybe one or two more questions. Since the heart is a muscle, does DM cause heart issues?
Oh, that's a great question. I love that question. So there are people who get myocarditis or pericarditis just from the autoimmune component of things. And so the treatment there is kind of similar to what you would do if you had other muscles involved. But I'm more worried about the atherosclerosis that can be seen at an increased rate in patients with dermatomyositis. And so one of the things that I do is I check a cholesterol, especially a lipid panel on all my dermatomyositis patients, and you should look at the LDL level. And probably the thresholds need to be lower than what normal people would be thought to be normal. And I find a lot of times the primaries are a bit hesitant to treat the elevated cholesterol, and they're worried about statins, which have on some occasions been associated with dermatomyositis. So it's really worth knowing that there are new drugs now, like ezetimibe or PCSK9 inhibitors that can really rapidly reduce cholesterol, especially the PCSK9, but are also not statins if somebody is concerned, the primary or whoever's going to treat that. I work closely with a preventive cardiologist, and I refer many of my patients with hyperlipidemia, high cholesterol, to the preventive cardiology division because they understand the disease and they understand the need for prevention. I think a lot of times regular cardiologists may just be used to treating once there's a complication, but I think we'd like to try to prevent that.
Okay. Do you have any final words, Dr. Werth, on anything that you would like to share with the patients, things that maybe you share with your patients on a regular basis that you would like to share with the audience tonight?
Well, I think I've shared a bunch of what I was thinking about. I do think that we need better therapies. And so if you're in an area where there's ongoing studies and you're not doing well, I would encourage you to be part of helping us get to better therapies. There really are some very important medications that are coming along that I think it's worth investigating further and being part of helping us get to better treatments.
All right. Well, thank you so much. We appreciate you being with us today.
My pleasure. It's been great questions. It's been really wonderful.
It has. We'll have to have you on again. So thank you, Dr. Werth, for being part of our webinar tonight. And thank you to the audience for tuning in. We have another webinar next month. One moment. It will be with Dr. Rohit Agarwal, rheumatology, and that will be let's see, May 19th at 6 p.m. Eastern time. And then we also would like to invite you to be a part of our Myositis Awareness Month virtual summit. That is May 21st, Saturday from 10 a.m. to 6 p.m. And you can register online at our website, www.myositis.org. For TMA, I'm Rachel Bromley. Thank you and good night.